Hi, everyone. Thank you all for attending my talk today. My name is Mina Nashid. I'm a BrainScan postdoctoral fellow working with Dr. Stephen Laviolette and Dr. Daniel Hardy. Today, I'll be speaking to you all about some of my work looking at neonatal and neuropsychiatric outcomes of prenatal cannabinoid exposure. First of all, I have no conflicts of interest to declare. Some quick background about this project. Based on some of the literature, the prevalence of cannabis use during pregnancy is upwards of 35% in North America. In the public, despite the increase of global legalization of cannabis, this has not been coupled with an increase of evidence-based policies, unfortunately. And there's this persistent perception of safety for both THC and CBD within cannabis, and often cannabis products are actually used for self-medicating anxiety and depression during pregnancy. In terms of the literature, the differential effects of cannabis constituents, so THC being the psychoactive component and CBD being the non-psychoactive component of cannabis, in pregnancy is not delineated. So there's not a lot of research looking at the differential effects of both of these constituents. There's also a stark lack of sex-specific studies looking at neurobehavioral outcomes for prenatal cannabis exposure. In terms of research design, we're looking at a rat model of prenatal cannabis exposure. And in one cohort of animals, we took pregnant dams and injected them throughout gestation with either vehicle, THC, CBD, or a combination of THC and CBD, and collected fetal and placental weights. In a separate cohort of animals, we allowed the pregnant dams to give birth using the same injection treatment schedule. And we collected pup and organ weights at postnatal day 1. We then collected pup and organ weights at postnatal day 21. And during adolescence, which in rats lasts from postnatal day 35 to 45, we performed a battery of behavioral tests looking at anxiety measures, impulsivity, cognition, and schizophrenia-like phenotypes. In terms of neonatal outcomes, there was no effect of treatment on litter size. However, for all treatment groups, fetal to placental weight was reduced, and that suggests to us placental insufficiency. At postnatal day 1, the brain weights of pups exposed to both THC and CBD was reduced compared to vehicle. Their body weights was also reduced. However, we didn't notice any change in brain to body weight ratio. And this suggested to us that pups exposed to combination treatment in utero underwent symmetrical fetal growth restriction. At postnatal day 21, we can differentiate between males and females, and we did not notice any difference in terms of brain weights, body weights, or brain to body weight ratios for any of the treatment groups for both sexes. In terms of behavioral outcomes, we first looked at the elevated plus maze test, which is a test for anxiety-like phenotype and impulsivity. In this test, animals are placed in an elevated plus maze, and this maze has 2 open arms, as you can see here, and 2 enclosed arms that have high walls. And animals are allowed to explore for 8 minutes and are recorded. And typically, reduced time spent exploring the open arms is indicative of an anxiety-like phenotype. However, when compared to vehicle, we can also look at increased time exploring the open arms as indicative of impulsivity, as well as increased time exploring the middle of the arena as another measure of impulsivity. And what we see on this test is that males that were exposed to both THC and CBD in utero had increased open arm exploration compared to vehicle, as well as increased entry into the open arms compared to vehicle, and increased time spent in the center of the arena. And this is indicative of an impulsivity-like phenotype. So there's increased impulsivity here for the males that were treated with both CBD and THC. By contrast, for the females, we didn't note any significant changes across the different treatment groups for any of the measures. Next, we looked at the open field test, which is another test for anxiety-like phenotype, as well as overall locomotor activity. And in this test, animals are placed in an open arena, and they're allowed to explore for 30 minutes. On this test, reduced time spent exploring the middle of the arena during the first 10 minutes of the test would be indicative of an anxiety-like phenotype. Over the 30-minute period, we can also look at overall locomotor behavior. And on this test, we actually did not note any significant differences between any of the treatment groups for both males and females, looking at the anxiety-like phenotypes in the first 10 minutes of the test, as well as overall locomotor activity for the 30-minute duration of the test. Next, we assess cognition using the temporal order novel object recognition test. And this test includes 3 phases that are 3 minutes each and set 1 hour apart. In the first phase, object A is introduced to the animals and they're allowed to explore for the 3 minutes. In phase 2, animals are introduced to object B. And in phase 3, animals are presented with both objects. And in phase 3, we analyze the explorative discrimination between objects. So typically, if a rat is not cognitively impaired, they will show a preference for exploring object A, since object B is more recent to them. And on this test, we see that for the males, all treatment groups led to a decrease in discrimination index score. And this is indicative of cognitive impairment in terms of short-term memory. So all 3 treatments, THC, CBD, and the combination led to this deficit in cognition for males. And this was despite the fact that overall exploration did not change between any of the groups. In females, we didn't note any significant differences between any of the groups. However, there was a trend here for the CBD group that showed a decrease in discrimination index, but did not reach significance. Another test for cognition is the sociability and social memory task. This task also includes 3 phases. So in the first phase, animals are habituated to the arena for 3 minutes. In the second phase, animals are then introduced to rat A and allowed to explore for 5 minutes. In the third phase, animals are introduced to rat B and allowed to explore for 5 minutes. Social motivation is analyzed in phase 2. Sorry, this is a typo, it should say phase 2 of the test. And we basically look at the discrimination between rat A and the empty cage during that 5-minute period. So animals should typically explore the cage that has rat A more than they would explore the empty cage during this phase. Social memory is analyzed in phase 3 of this test. So sorry, this is another typo, that should say phase 3. And in this phase of the trial, we're looking at discrimination between rat A and rat B. So rat B is the novel animal that's being introduced in this phase, and typically animals will explore rat B for longer periods of time compared to rat A as an index for social memory. And on this test, for males, we didn't observe any changes in social motivation or social recognition across the different treatment groups. We also didn't see any differences in terms of total exploration for either the motivation phase of the task or the recognition phase. In female rats, we didn't observe any significant changes in terms of social motivation. However, on social cognition, we saw that CBD did induce a deficit in social recognition. And although there were trends in the other groups, they did not reach statistical significance. Finally, we wanted to look at sensory gating using the pre-pulse inhibition test. In this test, rats are placed in a sound isolating chamber, and baseline startle response to an acoustic startle stimulus at 110 decibels is first established. So just the acoustic startle stimulus by itself. Then pre-pulses at 72 decibels, 76 decibels, and 80 decibels are introduced either 30 milliseconds or 100 milliseconds prior to the startle stimulus over multiple trials. And the percent inhibition of the startle response as a result of the pre-pulses is then analyzed. So typically a reduction in pre-pulse inhibition, meaning that the animal's startle response is not being inhibited by the pre-pulses, is typically associated with schizophrenia-like phenotype in both rats and humans. So on the pre-pulse inhibition for males, we can see that for any of the pre-pulses introduced 30 seconds prior to the startle stimulus, there were no significant changes across the groups. However, when pre-pulses were introduced 100 milliseconds prior to the startle stimulus, at 76 decibels of pre-pulse, we can see that CBD animals, as well as combination treatment animals, both had reduced pre-pulse inhibition compared to vehicle. For females on the pre-pulse inhibition, we did not observe any significant differences between any of the treatment groups across the different conditions that were tested. So in summary, to our knowledge, this is the first study that showed that both THC and CBD are associated with placental insufficiency. We also showed that combination treatment of THC and CBD leads to fetal growth restriction with catch-up growth by juvenile age, and this is consistent with what we see clinically. We also observed that THC and CBD impart sex-specific behavioral deficits on impulsivity, cognition, and sensory gating at adolescence. Overall, male offspring appeared to be at higher risk of deficits as a result of both THC and CBD exposure in utero. And for female offspring, interestingly, they seem to be more sensitive to the effects of CBD as opposed to THC in terms of cognitive outcomes. Some future directions and ongoing analyses. So we are currently looking at electrophysiological recordings of relevant brain regions, including the medial prefrontal cortex and the ventral hippocampus. We'll also be looking at molecular analyses of brain's placenta and blood samples for all of these offspring. We'll also be looking at structural analysis of the brains, looking at dendritic branching in the medial prefrontal cortex, as this brain region is important for the pathophysiology of neuropsychiatric disorders such as schizophrenia and depression. And we'll also be repeating all of these analyses at adulthood, which is about 3 to 4 months of age for rats. And with that, I would just like to thank my mentors on this project, Dr. Stephen Laviolette, Dr. Daniel Hardy, Dr. Walter Rushlow, as well as some of the students that have worked on this project with me, Mohammed, Kendrick, and Sebastian, as well as the whole addiction research group. And I would be happy to take any questions.
Good morning, dear colleagues. I would like thanks to organizers of the Joint Mental Health Research and Innovation Day for inviting me to present my research in this important day. I have joined recently LHSC Victoria Hospital, Western University, and I am specialized in general psychiatry and substance use disorders. The study I'm going to present today is among the research that I was doing during my fellowship between 2014 and 2015 in UCLA. And this is the last part of the study that we are working on. It's mainly about craving among individuals with stimulant use disorder, and we are studying the effect of exercise on craving. So as an introduction, the methamphetamine use disorder is a big crisis in the Western world, especially in the United States, with an age-adjusted overdoses reaching 3.9 from 100,000. And this is mainly related to overdoses. The major cause of this increase is the increase in availability, where there is a lot of behavioral, cognitive, psychological, and mental problems related to the methamphetamine use. All of these problems will lead to a change in the overall health status and quality of life, making the life quality more dysfunctional, and there's a dampening of the overall health. Till now, we're suffering with the treatment and the management of substance use disorders, especially methamphetamine, because there is no approved treatment. Although there have been many studies on the contingency management and the treatment of craving and methamphetamine use, but it is rarely applied outside the veteran system in the United States. So I'm introducing craving as an important aspect of the methamphetamine use disorder. It was defined in the DSM-5 as a newly introduced as an intense urge to use the substance that can occur at any time, it is a very high risk of relapse because it's a major predictor. The relapse occurs more rapidly with high cravers, and studies have shown that craving intensity scores were higher, 2.7 times higher in the patients who are relapsers compared to remitters. And craving can persist up to 5 weeks after abstinence and discharge from a substance treatment program. So the treatments for craving must focus on the psychophysiological parts and processes involved in this problem. And the promising practices might be cognitive-based skills, non-invasive neurostimulation, and mindfulness. But all of them have not been combined or applied efficiently in the treatment of craving in methamphetamine use disorder till now. So why choosing exercise as a method of treating craving in methamphetamine use? Previous animal studies have shown that exercise can attenuate reinstatement of methamphetamine in animal models. It also showed in the studies in smoking cessation that it decreases the strength of the desire to smoke and improve cue-related nicotine craving. So subsequently, the patient will use less cigarettes, and this will help in the abstinence. The only previous trial that studied the benefits of aerobic exercise on craving was done in China on 24 patients suffering from methamphetamine use disorder by Wang in 2017. And it showed that craving was attenuated by the exercise program, and the exercise facilitated normal and drug-related inhibitory controls. So in our study, we recruited 138 individuals suffering from methamphetamine use disorder who were treated in residential treatment to have either 8 weeks of exercise intervention for 71 patients versus 67 patients as health controls. And I will explain in the following slides what was the difference in the two interventions. This happened between 2010 and 2013 in Southern California. The inclusion criteria were for patients suffering from methamphetamine dependence. At that time, it was the DSM-4. The DSM-5 was not done yet, and the ages ranged between 18 and 55 for English language proficiency. Exclusion criteria were medical impairment that compromised safety, opiate dependence, or psychiatric disorders that mandated hospitalization at that time. So the procedures, we were comparing either exercise to the health education group by involving 60 minutes of 3 times per week of aerobic treadmill activity. And during this 60 minutes, you will have the patients will have aerobic treadmill activity with 1 to 2 sets of weight training. So it will be either the chest muscles, the upper limbs, or the lower limbs. And this will be going 3 times per week, compared to 60 minutes for 3 times per week of a health education on several topics, such as the HIV, the medical consequences of using substance, and general health topics like the diabetes and the hypertension, but with no focus on the cognitive behavioral skills or the contingency management, just not to interfere with the outcome of the study, because it was meant to be a control group. So craving was measured by the visual analog scale, and the patients were asked during the study and at the end, how much do they feel? And this was how much do they feel for the urge to use methamphetamine. The scores were from 0 to 100, and this was from week 0 till week 8. And this was only between admission and discharge. So they were not asked after discharge from the program. It was a self-reported, the methamphetamine use was checked by self-reported previous months of methamphetamine and asking them after discharge through substance use inventory and doing urine drug screens 1 month and 2 months post-discharge to check on the presence of methamphetamine. The average attendance was good, between 17.4 to 18.5. They were voluntary session, but to be noted, they were compensated by a $10 gift cards per session, which might have helped with the attendance. So the characteristics of the patients, of the 138 patients, there were 31.7 years mean age. The 29% of them were females, mostly Caucasian, non-Hispanics, and Latino. 31% suffered from, they had an HIV positive without an HIV disorder or symptoms at that time. 83.7 unemployed and 67.4 with high school education. So the results by study condition were that the health control had a higher weekly total mean craving score. And this was very clear when compared to the exercise group. So the red bar here showed the exercise group and the green bar showed the education group. And this is a mean craving score, which was significantly different between them. The average craving rating was significantly different from week 1. So this is comparing the weeks from week 1 till week 8. And it's showing here the red line, the red line was for the education group and the blue line was for the exercise group, and the craving scores differed from week 1 till week 8. So the lower craving average scores during the trial were associated at the end with less methamphetamine use, and this was clear on 1 month post-discharge and on 2 months post-discharge. By questioning the patients on their methamphetamine use due to the addiction scale, and by doing the urine drug screen. So 1 month follow-up, 77.3% of the high cravers had a positive urine screen for methamphetamine, and 88.2% at 2 months, compared to 22.7 and 11.8 in low cravers. So the methamphetamine users and the exercise significantly have lower craving scores compared with the health education group. Previous published reports on this in this study. So on the same study, we have previous 4 publications on different responses and the outcomes of the exercise, where the improved heart rate variability, reduced symptoms of anxiety and depression, increased dopamine receptor availability, and reduced methamphetamine use post-discharge. So controlling for the demographics baseline and baseline methamphetamine use and depression, the exercise was associated with significantly more craving over the trial. Low craving compared to high craving showed that there is a reduced methamphetamine use at 1 month and 2 months. And this was significantly different, significantly different relation between the reduction in methamphetamine use, the lower scores of craving, and mainly in the exercise group. So the limitations were that the residential treatment program do not generalize to other treatment conditions. These were very highly motivated patients being in a residential treatment, where patients will be competing with each other in fulfilling the requirements of the program and being enrolled in the exercise or the health education group. The adherence was high, maybe because of the incentives or because being in the program. And then outpatient, the adherence might be lower. We could not examine the sustained effects because it's just a short study and there's only 1 or 2 months follow-up, and there were no follow-up exercise treatments that were done after the discharge from the program. Also the Q-elicited protocols for testing craving would have been much better and more specific than the self-report, because the patients were not seeing methamphetamine or anything that reminded them with methamphetamine when asked about craving. So maybe testing craving with the Q elicited protocols could have been more efficient, and this population of patients, as we have said, were in a very highly motivated group. So it's worth testing patients who are maybe in the pre-contemplation phase, or they maybe not fully motivated to see how the effect of exercise will be. So as a conclusion, there is a broad array of benefits in the early months of methamphetamine abstinence. Definitely, we will need wider replication to explore the effects by looking to conditions such as mental health function, medical status, tobacco use, HIV, other psychiatric or mental comorbidities that were excluded from that study. The long-term effects need to be studied, so longer duration of exercise, maybe in an outpatient setting, maybe in a longer, and seeing long outcomes after a longer period of time could be much more helpful and much more pertinent for the outcomes, to study more the effect of exercise and see how it would be more helpful to combine exercise with other modalities of treatment, such as medications, meditation, and other cognitive behavioral skills. Thank you very much, and I would like to have your questions. Have a good day.
Treatment retention with monthly buprenorphine extended release injection. This is our study at the London RAM Clinic in London, Ontario, Canada. Data from the Public Health Agency of Canada from June 2021 confirms what we already know. In 2020, there were 17 opiate deaths daily, almost all of which were unintentional. And 80% of these deaths were due to fentanyl, and the vast majority, 99% of the fentanyl used, was non-pharmaceutical. Furthermore, 85% of stimulant toxicity deaths also involved an opioid. And one of the strategies to combat this is to use a opiate partial agonist, such as buprenorphine, which has a wider margin of safety than full agonists, such as methadone. A further step in the quest to decrease the potential for prescription diversion and to increase medication participation is to administer buprenorphine as an extended release monthly injectable. This is our study poster, which includes data up to 21 months, which is June 2021. And you can look at this later at your leisure, and I will summarize some of these findings. This is our study design. This is a cohort analysis of the first 75 patients treated with buprenorphine extended release injection at our addiction clinic in London. This report summarizes the data collected between October 2019 and June 2021, a 21-month period. Participants were enrolled in this cohort analysis based on their ability to access buprenorphine monthly injections. There was often difficulty attending a clinic every 4 weeks for the injections as planned, and this was analyzed. Participants had different start dates and stayed in the cohort analysis for variable periods of time. To account for this, Kaplan-Meier end-of-study estimates were done. 50% of the participants were able to get their injections on time or less than 2 weeks late. This is the 6-week treatment gap analysis. 60% of the participants were able to get their injections either on time or less than 2 weeks late. This is the 8-week treatment gap analysis. Median age was 38 years, males to females, was a 60-40 split. 44% were fentanyl users, and 36% had a history of previous non-fatal overdoses. Treatment retention for non-fentanyl users was 69.2%. Treatment retention for fentanyl users was 74.6%. This was not a statistically significant difference. This is a summary of the 34 participants who stopped receiving buprenorphine monthly injections during the 21-month period of analysis. 15 participants had a planned discontinuation from opiate agonist treatment. 19 of the 75 participants stopped buprenorphine monthly injections, and of these, 7 had returned to oral OAT. Approximately 50% of the discontinuations were after injection number 1 and 2. An analysis was undertaken of the 33 participants who used fentanyl, 44% of the cohort. They were most likely to leave the program early after 1 and 2 injections. They would typically require the higher 300 milligram maintenance dose. They would report blockade of euphoric effect when they did use fentanyl, feeling only sedation or fatigue. And more importantly, several returned to request buprenorphine monthly injections after leaving the program, and this accounted for the improved treatment retention at the 21-month analysis, giving a 70% treatment retention versus the 60% treatment retention at 15 months. And perhaps over time, the stability of buprenorphine monthly injections does resonate with fentanyl users, and this was felt to be a motivation in returning to treatment with buprenorphine LAI. Our conclusions and key findings are as follows. With the flexible reentry approach taken by the London RAM, some of the participants who left before the 15-month point returned to the clinic at some point in the next 6 months to resume treatment with buprenorphine LAI. All the participants who returned were fentanyl users, and only 40% of the participants received all their injections on time. There is a significant retention advantage to flexible reentry into the buprenorphine monthly injection program. If the 6 or 8 week cutoff was waived, participants can be easily restarted on buprenorphine monthly injections with a view to resuming the injection after a short period of stabilization. The treatment cohort retention jumped from 60% to 70% with the 6 versus 8 week versus flexible reentry criteria. The 2 main factors that appeared to be related to requests for the higher maintenance dose of 300 milligrams were the presence of chronic pain and prior use of fentanyl. 16 of the 75 participants received the 300 milligram maintenance dose, and of this number, 6 experienced chronic pain and 7 were fentanyl users. The stabilizing dose of oral buprenorphine prior to the initiation of monthly injection was not a strong predictor of requests for the 300 milligram maintenance, since participants were generally transitioned to the buprenorphine monthly injection as soon as possible. There were no deaths due to opiate overdose or apparent toxicity in the participants who were on the monthly injection. The analysis has been expanded beyond the initial 75 participants. To date, we have 150 patients that we were following, and this positive safety signal still holds.